Good morning, everybody. Welcome to SEVA VentRounds. Today is February 25th, 2025, and we have a very good, interested case today. 1 second, there's this little thing appearing. Quit. There you go. So let's get started. Our disclosures, there's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion, and it does not represent the Cleveland Clinic. Your host is myself, Eduardo Mireles, and Rob Chatburn. We're both here to guide this discussion today. The ground rules: keep your microphones muted. This is a recorded session, so that way we keep all the background noise as much away as we can. And if you want to make any comments, just put it on the chat or unmute yourself and make the comment at that time, and then mute yourself again. There are CME and CRCEs for those attending. I'll start just by putting this key SEVA knowledge. And in general, what we would like to see when we give a breath would be the breath when there's PMOS, actually, that the PMOS would start and trigger the breath, and then the pressure would end, or the pressure delivered by the ventilator would finish when the PMOS finishes. And so that would be the normal or perfect view. There's this concept of late cycle, and late cycle means that the patient does a breath, reaches the maximum in the contraction of the diaphragm, in the drop on the pressure, and you will see then you would expect the breath to end on time there. And instead of finishing on time, in this case, the mechanical breath ended later, and so later than the patient, and thus we call that a late cycle. In contrast, you have a breath that starts, and there's effort, that you can see the PMOS there, and the PMOS continues, and the mechanical breath, the inspiration ends. So meaning the set I time is shorter than what the patient neural time is. And as such, that leads to what we call an early cycle. And the way to recognize it, there's a couple of ways to recognize this event. One of them is the presence, for example, if you're in a late cycle, is the presence of this kind of shelf in which you see the flow being at zero. So essentially a pause during inspiration. And that means that the patient did effort, as you can see here, but there is this period in which there's no flow because the inspiratory time is longer. In some ventilators, actually, it will allow the patients to exhale during the process. And so you will see the flow go below while the breath is still being delivered. And then you have early cycle, in which what you will see, because there's still PMOS, what you will see is the flow. The flow is going to be amputated. So instead of having that beautiful peak that we see on all of them over here, you're missing it. You're missing all this area, and that's because the flow is now trying to reach baseline, moving towards the baseline, which means that there is PMOS, inspiratory PMOS. All righty. So with that, Rob, any comments?
Yeah, maybe just some comment around the word normal.
Yes, yeah.
It can be interpreted
Very
different
tricky,
ways.
right?
Yeah,
Go ahead, Rob.
Perfect cycling in this case, triggering and cycling, would be that the ventilator flow delivery exactly follows the PMOS, or the effort. But oftentimes, patient just makes a small inspiratory effort, and then there's a delay before the cycling. And that's a good thing because the patient is too weak to breathe on their own. We want them to have a mandatory breath. So in terms of clinical context, that's normal, but not perfect synchrony in terms of patient-ventilator interaction. Does that make sense?
Yeah, absolutely. And that's one of the challenges, right? In which you're saying, well, how can this be normal and this be abnormal over here? And in this case, I mean, there's muscle relaxation, but if it's pushing out during inspiration, that's a patient that is doing effort against the ventilator, right? Very tricky. This is why we need to get better definitions and align ourselves on what matters and what doesn't matter, and when does it become an issue and when it doesn't. Any other comment, Rob?
No, sir.
All right. So this image, and I know it has the sun glare, comes all the way from Barcelona, and this is Jordi Bañeros at Valdebron at their cardiac ICU. Took this picture and sent it to us. And so for those of you that are looking at the screen, you may recognize this is in Spanish. So you have the mode up here. You have P pico means the peak pressure, the exhaled minute ventilation, the exhaled tidal volume, the frequency, the I to E ratio, and yeah, the rest are relatively easy to understand. So what would be the tag for this mode?
No responses yet.
Okay. Now remember, you can use your ventilator mode map. All of them are tagged there, or simply you may already have memorized some of these modes.
There we go. We got
All
a
right.
pc-cmvs.
Yeah, good job, Ariel. So pressure control, CMV, yes. And what that means is that during inspiration, the variable that we're controlling is pressure, and we can see that here, the flow actually pretty consistent throughout of them, but there's different configurations, and you can see that sometimes it actually goes below the baseline. But this is pressure control. And then it says CMV, which means continuous mandatory ventilation, meaning that we set all breaths are mandatory. And so in this case, all of them are either triggered or cycled by the machine, by the ventilator. And in this case, you can see these little triangles here that are telling you that the patient is triggering the ventilator, but all of them are being cycled. It has the same inspiratory time, and they're being cycled by the ventilator. And so that's why all breaths, even though they're triggered by the patient, they are mandatory. And as for set point, because we set all the variables, the inspiratory, the pressure above PEEP, the inspiratory time, the rise time, and whatnot. Rob, comment?
Yeah, just the fact that the inspiratory times are so very consistent makes you think that these are time cycle breaths, which means every breath we see being supported by the ventilator is mandatory.
Wonderful. So then the question, next question is, what is the load? What is going on here? Is it elastic, resistive, or is there presence of PMOS? There you go, Anika leading the way with a lot of PMOS being present here, right? Good job, Ben Busters. Well, what you start seeing here is the presence of PMOS, and practically throughout inspiration and expiration, it's a dominant load. And you know that because you don't see, and I'm gonna go back one slide, you don't see this beautiful, nice decay during inspiration. Instead, you see this kind of sinusoidal waveform. So I'll go back to the image that we had. So you can see, even though this is the gain in this ventilator, it looks relatively small, but you can see that sinusoidal instead of a exponential decay. And then during expiration, you barely see a little phase for expiration, so you cannot really see if this is a decay or the patient is doing effort. Rob?
Yeah, the PMOS is indicated on inspiration as being probably both positive and negative, right? The fact that the flow goes below zero during the preset inspiratory time probably indicates that the patient's trying to exhale.
Correct.
And some ventilators will let them do that and some won't.
Yes, I love that. So we're gonna talk in a second about the what's going on during inspiration. So thank you, Rob. Let's focus on that too. I wanted just to highlight that sometimes these graphs are very good when you're seeing. So you can see here that we're seeing 5, 10, 15, 20, 25 seconds of ventilator tracing. So sometimes it's important for you to, when you're trying to ascertain what type of interaction is happening, you can change the the amount of time that you're going to be displaying in your waveforms, and that will make it bigger. And when you make it bigger, and you have a little bit the ability to recognize those interactions a little bit better. So now I saw questions flying, but we're going to address expiration in a second. So let's talk a little bit about trigger. And so I would ask you, what's the discordance that you see in terms of trigger? Is it normal, early, late, false, or failed? Anybody? Normal? 50-50. There you go.
Yeah, good, Annika. There we go.
Yes. So what we're hearing here is that there's normal, and then there's the concept of failed. So let's go at it for a second. Yeah, thank you, Michael. So you see that every breath there's this little triangle down here, and it's telling us that it's a patient trigger. And actually, there's features that tells us that there is PMOS. So do I believe this triangle that this is PMOS? I think so, because I see the pressure drop, which is not always present, but now you see it, and you can see on each one of them from the level, it drops. The second one that you see is how the flow crosses from expiration to inspiration. So it looks all true to be, and so the ventilator is pressurizing immediately. So I think that you're absolutely right. This is a normal breath. And then if you follow what the team is recognizing is these crossovers over the baseline, and it's essentially a one-to-one. So there's a normal breath, and then there's this attempt to cross over the baseline, but it's not triggering a breath, right? There's no triggering. Actually, you may even see how the pressure seems to be dropping below baseline as you are doing this item. So you have normal breaths followed by a failed breath. And since we're on this part of the failed breath, normally, I mean, and this is a flow trigger breath, meaning that the flow has to achieve a certain value for it to trigger a breath. But if you look at it, it has actually pretty high flows that it's not even triggering. And the question is why these ones do trigger and these ones don't. Rob, do you want to talk about what's happening there?
Well, just first, you'd mentioned that this is flow triggered, and you know that because the color of the triangles is the same color as the flow waveform.
That's correct.
The flow is going above zero, but it's not triggering on flow. So the first thought might be that the flow trigger sensitivity, the flow trigger threshold is set too high, or the sensitivity is too low. And at the end of the expiration, where the expiratory flow rapidly or abruptly goes towards positive, and the patient's making a large inspiratory effort, and apparently enough to cause the flow triggering.
So I wanted to talk a little bit about the synchronization window and how there may be periods in which you may not be able to trigger like a refractory period immediately after an inspiratory breath. Do you think that this may be the cause of that failed trigger there, Rob?
Yeah, I skipped over that. Different ventilators have different refractory periods. what that means is every ventilator will put in a short period of time right after the breath ends, after flow goes through zero, where during that time, no trigger effort will be recognized so that you don't get breath stacking. Ventilators build that in for every mode that has mandatory breaths, but there's no clear rules, and oftentimes you can't even tell in the operator's manual how long that period is. So that was probably a more likely explanation, because that peak in flow crossing zero is still very close to the end of the preset inspiratory time.
Excellent. Thank you, Rob.
You might want to draw a vertical line where the ventilator thinks the end of expiratory time is.
Yes,
right
the
there,
end
yeah,
of right here.
So the space between the vertical line and the arrow is probably the refractory period, or very close to it.
Correct. Something along this amount of time. So, and I saw several members of the audience talked about that there was essentially a 50-50 or a 1-to-1 amount of normal trigger and then failed triggers, and that the respiratory rate of this patient, even though here it says 22, it's actually probably higher than that, so double of that. Now, let me ask you about inspiration. Is there assistance, over assistance, or under assistance? How would you rate this interaction?
We have 1, 2, 3 unders and 1 assistant.
This is I love it. Thank you very much for talking on this, because there's periods of the breath that seem assisted. So if you think about the first part of the breath, I'm going to make this big for a second so that we can see it. If I can, yeah, whoa, all right. And remember, I cannot paint over here, but you can see the little hand. But during the beginning of the breath, the patient is getting assistance, right? I mean, the patient is doing a fair amount of PMOS, but this one is assisted. Then this part of the breath, the end of the breath, actually the patient is exhaling against the pressurization that the ventilator is doing. So assisted, and over here the patient is essentially breathing against the higher pressure that is set. And then this breath, where the patient does effort and it fails, is essentially unassisted, right? Actually, it's a loaded breath. You can see how the pressure drops and below the baseline. And so this is an under-assisted environment. So assisted, work against the ventilator, work against the ventilator. Rob?
Yep, that's very good. Loaded, the word loaded means the patient's actually doing work on the ventilator, trying to, and not getting anything for it.
So this is, I really love this example from Jordi, because it brings some of the challenges that comes from, I mean, this is a very nuanced assessment of what's happening on the interaction with the ventilator. And you can imagine that this requires obviously a change of what we're doing, and we'll show you how it changed. But the concept of, well, it's assisted a little bit, but there's a lot of work and a lot of wrong that is going on at the same time. Now, how's the cycle? Normal, early, or late?
Late and an early. One late,
so remember that we do this in reference to the PMOS. So in this case, you can see that the PMOS of the patient is this long, and then the ventilator inspiratory time is this long. So the ventilator is finishing later than the patient, And so this is actually a late for the breaths that are normally triggered. That's a late late cycle. And then finally, for exhalation, I cannot make a very good assessment here, but my suspicion is that there is effort during expiratory work. It doesn't seem to be falling in an exponential way, but it's so short, and the time limits are so the time scale is so small that I cannot really read it. But I suspect that there was expiratory effort.
Yeah, so, this looks like a patient that's panting in and out, right?
Yes, exactly.
And again, when the magenta flow waveform goes below 0 during the preset inspiratory time, that's your indication that the patient is actively trying to exhale, and the ventilator isn't allowing it. And again, that's the definition of late cycle, right?
Exactly. So when you see this case, this is one of those, and the rule that we use to read ventilator waveforms is treat the first discordance that you see. Okay, and this is kind of tricky because you have 50% of your breaths are normal and 50% of them are failed. And so you may be thinking, well, do I treat the failed trigger or do I treat the first that appears is not the normal trigger. The first one that appears is actually this late cycle, a late cycle. And so do you treat the late cycle or you treat the failed trigger? Let's ask the audience, what would you treat? And I saw a lot about, well, what's the goal and what's the station, but just for the sake of it, which one do you think that you should treat? The late cycle or the failed trigger?
Yeah, right? Mohammed says don't give sedation. It's not the answer.
Don't give sedation?
Rather than sedation is what he said.
Yeah. Very good. So I saw a late cycle. Anybody else? Failed trigger, question mark. So that means 50-50. So what we ask what the team did over there was, and I think let's just for a second think about this, all right? And I'll show you what the team did in Valdebron. You already did, but so you have a trigger, right? You have a normal trigger, and then you have a late cycle, and the failed trigger in this case is due to the late cycle because that's causing that refractory period. So the only way to fix that is to get the I time fixed. Once you fix the I time, then the failed trigger will disappear because the cause of the failed trigger is that it's falling on the refractory period. So what they did immediately on this patient was to change the patient to spontaneous breaths. Simply did that. Just went from, if you see the values, from pressure control, which of delta inspiratory pressure, to pressure support. And with that, neural inspiratory time matches the ventilator inspiratory time. And now the patient stops fighting the machine, and you have still inspiratory effort. You can see that this is not falling and decaying as you would. The patient's tidal volume went up. So it went from 244 to 359. But now the patient is exhaling passively. Now, this one over here, forget about it. This is a transition from the graph. So we cured, exactly, thank you, Rob. It took care of the problem. I mean, this is a domino effect, right? If you don't treat the cause, the late cycle was causing the failed trigger just by moving this. And so now the patient was fighting against the ventilator. You can imagine this could have led, regardless of your goal, to either more sedation or more interventions for a patient that was simply with a setting that was not being helpful for them. No, the failed trigger happened because there is the refractory period, Rana. That's the message over here, is that there's a period in ventilators that goes immediately after the flow the expiration starts, and it changes between ventilators. Some have it smaller, some doesn't have it, some have it, but this prevents the ventilator for giving several breaths in a row, so multiple triggering. So there's a refractory period immediately when expiration happens, and that's what probably is causing this. No, but you're saying neural time, the respiratory rate is 20 because the patient stopped fighting the breath, and now it's probably getting a better tidal volume, is more comfortable, and then that went down. It was fighting against the machine.
You can't tell what the neural inspiratory time is without a PMUS signal, and it's not very evident by looking at the waveforms.
Correct.
And
but at least on this one.
Oops.
Go ahead, Rob.
I wanted to add one thing, that I've seen people look at waveforms like this at the bedside, and their first reaction is, well, why don't we just shorten the I time in CMV? And sure enough, if you stand there and fiddle around with it, you might get the synchrony to go away for a short period of time. But it's probably not a long-term cure, because as soon as you walk away from the bedside, the patient's condition can change and you're right back into it. So the better option is to let the patient trigger and cycle, and don't impose an inspiratory time on them if you don't have to.
Oh, I love that thought. And actually, I would say that many ventilators, and I believe this one also does that, when you have them on pressure support, it will tell you the inspiratory time. So it may be a way for you to measure, and actually, instead of guessing, setting that value for your inspiratory time when you're in pressure control.
If you definitely had the higher pressure, yeah.
The other item that I appreciate what you're putting there, Ariel, that we fixed the late cycle, but as you may recall, we also read that there was under assistance. And so by increasing the amount of support, this patient got more support than before, and you can see how the interaction became much better. And so there's this concept that sometimes we hear of, oh, put them on a rate so that they can rest. And if anything, this is one of those cases in which it becomes very evident that it's not the rate that is supporting them and making them rest less, or the inspiratory time. It's actually the amount of support, the amount of pressure that is being provided by the ventilator. So with this, what we would say the key findings on this case is you need to recognize the late cycle and have other effects. We also learned and reviewed the refractory period that happens during when the ventilator cycles the inspiration, and this is different in different ventilators. And in this case, it was causing, our suspicion is that that's the cause for the failed triggers that we were seeing. So, and then we also talked about the presence of under assistance and work shifting that was occurring during the breath, during those small breaths. And how did we solve this? We solved it by changing to pressure support, right? And that allowed the patient to regulate itself the ventilator inspiratory time, instead of having us thinking what the patient needs. And we increased the pressure support, which decreased or improved the assistance. So it gave more assistance. Rob, any other take-home messages?
Yeah, another key take-home message here is that you have to treat the primary synchrony problem first. So that means you have to recognize them as distinct things, late cycle versus failed trigger. And you have to realize that the failed trigger was caused by the late cycle. So the late cycle is the primary synchrony problem. Treat that first. Is if you went in there and tried to fix the failed trigger, let's say by fiddling around with the sensitivity, first of all, it wouldn't have worked. And second of all, you'd be wasting time and causing the patient to struggle unnecessarily.
I love it. Thank you, Roberto. Here are the CME and CRC for our RTs. And again, I'll invite you to register for the SEVA course. We are almost full for April, but there's still slots. So if you're interested, this is the time. And in the course in April, we're going to see actually all you can go if you choose to all the way to the master's certificate. Thank you very much and have a great day. Thank you, Roberto. Hope everybody is doing well. Bye-bye.